Hello, my name is Dr. Dewan S. Raja. Today I will discuss multiple choice questions on Stevens-Johnson syndrome and toxic epidermal necrolysis, also called TEN. Question number 1. A 25-year-old man presents to the emergency department with a 3-day history of fever, malaise, and painful red eyes. He also developed painful oral ulcers and a generalized rash over 9% of body surface. On examination, he has targetoid lesions with central dusky areas and mucosal involvement of the mouth and conjunctiva. He recently started taking lamotrigine for bipolar disorder. Which of the following is the most likely diagnosis? Choice A. Erythema multiforme minor. B. Stevens-Johnson syndrome. C. Toxic epidermal necrolysis. D. Herpes simplex infection. E. Bullous pemphigoid. What is the right choice? We have history of drug, 9% body surface area present, fever, malaise, painful red eyes, oral ulcer, generalized rash over 9% body surface. So our answer should be Stevens-Johnson syndrome. Stevens-Johnson syndrome. Okay, so this is the image of Stevens-Johnson syndrome, and this has been taken from Google. It is a part of the Cleveland Clinic publication. This is the Stevens-Johnson syndrome. Will get rash over the body. If it is less than 10%, then it is Stevens-Johnson syndrome. Question number 2. 10-year-old boy develops fever and malaise followed by the rapid appearance of widespread skin lesions involving less than 10% of body surface area and extensive oral mucosal ulceration. He was treated with sulfamethoxazole trimethoprim for a UTI, that is urinary tract infection. This is the cotrimethazole. 1 week ago, Nikolsky's sign is positive. Which of the following best describe the pathogenesis of his condition? A. IgE-mediated mast cell degeneration. B. Immune complex deposition in dermal vessels. C. T-cell-mediated keratinocyte apoptosis. D. Antibody formation against desmoglein. E. Complement-mediated lysis of basal keratinocytes. What is the best described pathogenesis of this condition? Answer should be T-cell mediated keratinocyte apoptosis. That is the programmed cell death. Keratinocyte is a layer of the stratified squamous epithelium. So this is the answer, T-cell mediated keratinocyte apoptosis. Question number 3. A 40-year-old woman with epilepsy presents with diffuse skin detachment and mucosal erosions. She started phenytoin 2 weeks ago. A biopsy of skin shows full thickness epidermal necrosis with minimal dermal inflammation. What is the most appropriate next step in management? Okay, this is a serious issue. Diffuse skin detachment, mucosal erosion. Okay, it is a full thickness epidermal necrosis. So this is a picture of 10, and we have the next step management. Begin high dose corticosteroid. B. Immediate intravenous penicillin. C. Discontinue the offending drug and provide supportive care. D. Begin antiviral therapy. E. Perform surgical debridement. Answer should be C. Discontinue the offending drug, that is phenytoin, and provide supportive care. Answer is C. Okay, so we got that. Answer is C. This is a typical management for the For the toxic, for the TEN, there is toxic epidermal necrolysis. Okay, also similar to that of the Steven-Johnson syndrome, but here we have skin shows full thickness epidermal necrosis, so it is an example of TEN, toxic epidermal necrolysis. Our management is this: discontinue the offending drug and provide supportive care. Question number 4. Which of the following drugs is least likely to be associated with Steven-Johnson syndrome? A. Allopurinol, B. Carbamazepine, C. Ibuprofen, D. Acetaminophen, E. Sulfonamides. All of them cause this problem, SJS or TEN, except this least likely chance. This is the acetaminophen or Tylenol. Okay, this is the paracetamol, and this doesn't usually cause, it is unlikely to have Steven-Johnson syndrome. So our answer should be acetaminophen. Question number 5. A 35-year-old man with HIV develops fever, conjunctivitis, widespread purpuric macules involving 20% of his body surface area. Several mucosal sites are affected. Skin biopsy confirms interface dermatitis with keratinocyte necrosis. What classification does this patient's condition fall under? So here 20% body surface area is affected. These are the choices: erythema multiformis, bullous pemphigoid, Steven-Johnson syndrome, toxic epidermal necrolysis, E. Steven-Johnson syndrome, splash, toxic toxic epidermal necrolysis overlap. Our answer should be, from this case history, E. Steven-Johnson syndrome and toxic epidermal necrolysis overlap. It is 20%, and dermatitis, keratinocyte necrosis involvement is fever, conjunctivitis, or spread purpuric macules. Our answer should be this. If it is less than 10%, it should be just this, Steven-Johnson syndrome. If it is more than 30%, it should be toxic epidermal necrolysis. So it is in between them, Steven-Johnson syndrome and toxic epidermal necrolysis. Question number, we are seeing the image of toxic epidermal necrolysis. It is a wiki-EM image. Here we are seeing this, the picture of toxic epidermal necrolysis. Question number 6. A 38-year-old woman presents with high fever, malaise, and rapidly spreading rash that started 2 days ago. She was recently started on Lamitrozole for bipolar disorder. On exam, there is a widespread erythema, flaccid bulla, and skin detachment involving over 35% of body surface area. Mucosal erosions are noted in the oral cavity and genital region. Nikolsky sign is positive. What is the most likely diagnosis? Our answer should be 35% body surface area, not this Steven-Johnson syndrome, bullous pemphigoid, pemphigus vulgaris, drug-induced erythema multiformis. No, our answer should be D, toxic epidermal necrolysis. This is the toxic epidermal necrolysis. Question number 7. A 45-year-old man presents with extensive skin peeling and mucosal erosion after taking sulfonamide antibiotics 10 days back. He is diagnosed with toxic epidermal necrolysis. Biopsy would most likely show which of the following: A. Subepithelial blister with eosinophils, B. Full thickness epidermal necrosis, C. Acantholysis in the stratum spinosum, D. IgA deposition at dermal papilla. E. Lymphocyte infiltrate with neutrophilic microabscesses. Answer should be B. Full thickness epidermal necrosis. Full thickness epidermal necrosis. Okay. Question number 8. Which of the following medication is most strongly associated with an increased risk of developing toxic epidermal necrolysis? A. Azithromycin. B. Amoxicillin. C. allopurinol. D. Ranitidine. E. Clopidogrel. Our answer should be C. Allopurinol. Okay, this is the answer. Answer is C. Allopurinol. Okay. Question number 9. A patient with toxic epidermal necrolysis involving 40% of body surface area is being treated in the ICU. Which of the following intervention is most appropriate as part of the initial management? A. Broad spectrum intravenous antibiotic for all patients. B. Immediate corticosteroid therapy. C. Transport to burn unit with fluid resuscitation and wound care. D. Skin debridement of necrotic areas. E. Daily systemic anticoagulation. Here is which of the following is the most appropriate as part of initial management? Answer should be C. Transport to burn unit with fluid resuscitation and wound care. So C is the right choice. Transfer to burn unit with fluid resuscitation and wound care. C is the right choice. Then we'll go to the question number 10. Which of the following clinical variables is part of the score 10 severity index used to predict mortality in patients with TEN? A. Number of mucosal sites involved. B. Degree of erythema. C. Total bilirubin. D. Age more than 40 years. E. Presence of eosinophilia. So, which of the following clinical variables is part of score 10 severity index used to predict mortality in patients with TEN, that is toxic epidermal necrolysis? Answer should be D. Age greater than 40 years. D is the answer. Age greater than 40 years. Okay, so these are the answers here. And that's all for today. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful and blessed day. Bye now.